Good evening, everybody. It's my pleasure to be presenting this lecture about Chandelier-Scleral Buckling, Back to the Future. In spite of the difficult times we are passing all through the world, but still we think that this may be a blessing because we have some time to distribute science, and maybe we have some time to prepare our lectures and prepare our studies and to publish it. So I hope, in spite of this very difficult times we are passing through, I hope that this will be a good time when we remember it later after the crisis had passed away. Due to this corona crisis, I have to postpone our Alexandria Retina Summit 2020 to the 18th and 19th of June 2020. And I hope that all of you will be attending with me at that time, and at that time we will be passing the crisis and the stress of the coronavirus. My lecture is mainly concentrated on the Chandelier-Assisted Buckling, wide-angle viewing systems, what we call the WAV, in addition to the Eckert twin light, which had changed my trends in treatment of pseudophakic retinal detachment. If you go back to the history, we can remember that James Warr in 1756 to 1815, an English eye surgeon, first described the retinal detachment. Also, he had attempted the first surgery for retinal detachment and suggested the drainage of subretinal fluid by puncturing the sclera with a knife. Also, von Grave in 1870, a German ophthalmologist, considered one of the most important figures in the 19th century, he modified the method of surgery by also puncturing the retina and creating a second hole for drainage of the subretinal fluid into the vitreous cavity. Conventional scleral buckling surgery is referred as conventional or external retinal detachment surgery, in which surgical implant is sutured to the sclera to create an inward indentation. The term buckle refers to the formation of a structure under stress. Charles Kippens, 1912 to 2006, was regarded by many in the professions as the father of modern retinal surgery. He invented the binocular indirect ophthalmoscope. He also pioneered the surgical technique of scleral buckling, which raised the success of retinal reattachment surgery from 40 to 90%. However, this indirect ophthalmoscope was the mainstay of management of conventional retinal detachment till late in this century. But I will show you how the indirect ophthalmoscope should be replaced by the WAV, or the wide angle viewing system. Jules Gonin, in 1870 to 1935, a professor of ophthalmology who pioneered the procedure of ignipuncture, in which the first successful surgery for treatment of retinal detachment was done. He was the one who first described that retinal detachment was caused by the presence of retinal break and sealing of these breaks is the prime factor responsible for successful reattachment of the retina after. Ernst Custoids was the first to describe the placement of a polyvial explant that was sutured to the sclera overlying any retinal break, and this was an easier technique and quicker to place. There is minimal damage to the sclera. The configuration and the height of buckling effect can be selected more easily. Cryotherapy was popularized by Linkoff in later part of 1960. It was applied through full thickness sclera with causing significant damage and can be applied to treat detached retina. It uses nitrous oxide gas to produce cooling up to 89 degrees centigrade. Also, Linkoff had proposed and pioneered an understanding of the patterns of retinal detachment and defined the important Linkoff rules of how to find the retinal break in retinal detachment. These rules are still applicable up till today. In Alexandria and in Egypt, Professor Ahmad Amin Rufai had introduced the method of scleral buckling in 1956. Now we have to remember that since 45 years, this was the innovation by pars plana vitrectomy by Robert Machmer, and he was able to remove the inward part of an egg through drilling from outside, and this was the idea behind the vitreous surgery. And from that time, there was a shift towards vitreous surgery more than buckling. Again, I have to remember the book of Murray Bonnet, Microsurgery of Retinal Detachment, in which she had described retinal detachment in pseudophakic eye, and they are usually more extensive with macular involvement and PVR. It's also much more common than retinal detachment in phakic eyes. The tears responsible for pseudophakic retinal detachment are often small and anterior placed at the insertion of the vitreous band or the vitreous base. Many studies have shown that pars plana vitrectomy is superior to scleral buckling surgery in eyes with pseudophakia, media opacity, and peripheral capsular opacification are more common with more incidence of missed breaks, and was the characteristic of pseudophakic retinal detachment while using the indirect ophthalmoscope or the slit lamp biomicroscopy on the operating microscope. However, the combined use of WAV and chandelier twin light had being more popular in this century to treat retinal detachment, and it became in my hand the most preferred method of treating of retinal detachment without. And I will show you one of my first cases, a case of an upper temporal retinal detachment in a pseudophakic patient without any complication in the anterior segment part of the eye during the cataract surgery. And as we traditionally was taught that we go for vitrectomy. However, I will show you that the Chandelier-Assisted Buckling had succeeded in reattaching the retina with minimal problem. These are still images of the procedure. We start by indentation over the area of the retinal break, as you can see in the upper left hand side figure, and then localization and treatment of the break, as you can see in the right upper hand still image. Then we screen the peripheral retina for any other breaks, place a 41 band and drain the subretinal fluid. And as you can see in the right hand side, lower right hand side pic, that the retina is reattached with the buckle pressing on the side of the break. And this is the video of the surgery. We'll start by buckling, and we start by localization of the retinal break, treatment of the retinal break by cryo, placement of the 41 band in the area of the retinal break after localization on the external sclera, drainage of the subretinal fluid, and the retina is reattached on table. And you can screen all over the retinal periphery, and you are sure that you don't have any missed breaks, especially in this type of pseudophakic retinal detachment, in which the breaks are characteristically very small flap tears at vitreous base. And using the operating microscope with the WAV and the chandelier helps you to examine the retina under magnification, sharp focus, zooming XY all the time. There is no probability of any missed breaks during that procedure. Again, this was the post-operative appearance of the patient 1 week following the surgery, with residual gas bubbles in the upper part of the vitreous cavity, and the retina is attached. Again, this is the post-operative appearance of this pseudophakic patient with the retina completely attached 1 month following the procedure, with no evidence of any recurrence or any missed retinal break. Again, this is an upper temporal retinal detachment in accordance with Linkoff rule that you have to look for the retinal break within 1.5 clock hour from the most superior temporal part of the detachment, and it was there. Again, treatment by cryo, placement of the 41 band on the sclera at the area of the break, drainage of the subretinal fluid, reattachment of the retina, and injection of gas or air inside the vitreous cavity to give a pressure for continuous drainage of the subretinal fluid and tamponade of the retinal break. A trivial instance which we were not able to observe during examination by the indirect ophthalmoscope was the presence of retinal incarceration inside the drainage sclerotomy for drainage of the subretinal fluid. However, in this case, the incarceration was very minimal, so we didn't have to revert to any retinectomies or to support the area of the incarceration by readjustment of the retinal buckle. Again, this is another proof of the Linkoff proposal of how to find the retinal break. A case of inferior bullous retinal detachment, you have to search for the retinal break in the uppermost part of the retina, corresponding to the highest bully of the inferior retinal attachment, and there was the break. If you look to the single surgery success rates for restoring pre-detachment vision, I have to present this case with a patient who had presented to me in 2008 with right rheumatogenic pseudophakic retinal detachment. The patient had been operated by buckling. And this was the post-operative appearance of the patient in 2018 with a visual acuity of zero point 0.4 with the retina attached, although the buckle was high with myopic shift. He had presented again in 2018 with his other eye with the rheumatogenic retinal attachment, in which I had to operate by vitrectomy. And the patient had a vitreous surgery with silicone oil injection. But this was the post-operative appearance with two vitrectomies and silicone oil injection, and the patient has intraretinal fibrosis, which you can see in this fundus picture. The silicone was removed in 2019, and with this fundus picture, although the patient had a reattached retina, but with very poor visual acuity. So we can compare both the outcome in his both eyes by different maneuvers. Again, this is another case of right rheumatogenic retinal attachment operated by Chandelier-Assisted Buckling, and this was the post-operative appearance with the retina attached with a good visual outcome. If you look to the recurrence after buckling and vitrectomy, this patient had a previous local buckle to an upper horseshoe nasal break. 2 years later, he developed recurrent retinal attachment due to a new retinal break in the upper temporal area. And although this patient had previous buckling procedure, he didn't progress so fast after the incidence of the recurrence and the new break. So I decided to go for chandelier assisted buckling in this pseudophakic recurrent retinal. Was the procedure. As you can see, there are the area of previous buckling and the local buckle, localization of the new retinal break, treatment eye cryo, placement of the 41 band circumferential manner on the new break, drainage of the subretinal fluid, and air injection. Again, this was the post-operative appearance with the air still there, and you can see in the upper temporal part of the picture the area of the new break treated by cryo. If you compare to the recurrence after vitrectomy, in which the vitreous is fluidy, this is one of the most emergent conditions in retinal practice. Recurrent retinal detachment due to sclerotomy retinal break, and this patient develops very rapid retinal detachment. If you don't interfere very fast, then you will be confronted by the worst type of PVR, and in this patient, he was postponed due to the weekend vacation, so I had to operate on him after 48 hours, and the This was the picture on operating on him 48 hours after the development of a retinal break related to the sclerotomy, very aggressive PVR, very adherent membranes, and this was ended by a retinectomy to flatten the retina. There are some complications related to the procedure as submacular hemorrhage due to the drainage side, although this is not inherent to the chandelier-assisted buckling, but it can occur with any retinal detachment surgery, especially buckling procedure. This hemorrhage is usually absorbed by time, however, it is replaced by macular mottling of the macular area of the retinal pigment epithelium with poor vision. Again, intrusion of the dacron sutures, as you can see in the upper temporal part of this picture, inside the vitreous cavity. This can be left if it does not induce reaction or perforation of the retina. Again, buckling, if so high, can induce myopic shift for the patient. However, by adjusting the height of the buckle, you can reach a certain level of myopic shift which is acceptable. Chandelier-assisted buckling again can be complicated by PVR, as in this patient in which was operated. The retina was flat. However, he developed PVR, and this was his fundus picture following the development of the PVR. And you have to go back to the operating room, and you can go for vitrectomy at that. Again, this was the post-operative fundus appearance of the same patient following vitrectomy and injection of silicone oil. Inferior retinal break has special consideration. It's very difficult to tamponade the inferior retinal breaks by vitreous surgery because any type of inferior retinal break cannot be tamponated by silicone oil or by gas except if the patient is placed in a hyperextended position, which is very difficult for the patient to be placed on it. Another example of an inferior retinal break in which chandelier-assisted buckling was used, and this is the preoperative appearance with the break around 7 o'clock. Same procedure was done: localization, treatment, drainage, buckling, air injection or gas injection. And this is the post-operative appearance with the inferior break completely supported. Even inferior retinal breaks with some PVR in the range of grade A can be treated without vitrectomy, especially if the patient have mild degree of vitreous reaction. Again, treatment by cryo, placement of a radial sponge, drainage of the subretinal fluid, and gas injection. And this is the post-operative appearance with the retina completely attached with the break completely treated. If you compare between the expenses, the vitrectomy procedure is very expensive. The vitrectomy pack is around $500, while the cryo machine use fee is around $20. A nice part of the chandelier-assisted buckling that you can convert easily to vitrectomy since you have the chandelier inside the eye and the machine ready. If you are confronted with any problem, you can directly convert to vitrectomy in just few seconds. However, there are some cases with large breaks in which you had better go for vitreous surgery from the start, as you can see in this patient. Again, this is the post-operative appearance of the same patient with the retina flat by vitreous surgery. In conclusion, twin light assisted scleral buckling, twin light chandelier and recite for primary retinal detachment in pseudophakic retinal detachment is a better alternative to classic surgery with indirect ophthalmoscopy and for vitrectomy. With the newer technique, there are many advantages over the traditional one in pseudophakic retinal detachment, such as clear direct retinal image that can be enlarged and sharply focused even with small pupil, easier detection of small retinal breaks in pseudophakic retinal detachment with media opacity, wider angle of viewing, better illumination, ease operation for the surgeon, saving his neck and back muscle, a good teaching technique for fellows and residents. Thank you for your attention.